Hello, everyone. Thank you for joining us for today's webinar on silver tsunamis. How are Native communities preparing for an aging community? This webinar is being hosted by the ANA Pacific Basin. Before we start, I just wanted to talk a little bit about ANA. So ANA promotes self-sufficiency for Native Americans by providing discretionary grant funding for community-based projects and training and technical assistance to eligible tribes and Native organizations. If you have any more questions, feel free to ask us anything in the chat bar or contact your local ANA regional office. Today's presenters will be myself, Shisaka Haunaile. I am the Outreach Project Specialist for the Pacific region. And helping me today would be Matthew Ng. He is our Technical Assistant Specialist, also for the Pacific region. So today's webinar is about silver tsunamis. This refers to the influx of senior citizens, which are elders, as modern medicine increases life expectancy. The surge comes from the baby boom generation, which was born from about 1946 to 1964. And this was the substantial rise in birth rates following World War II. That means they are about 54 to 72 today. So by 2029, all baby boomers will be 65 years or older. And at that time, 20% of the US population will be over 65, compared to 13% of the population which will be over 65, which was over 65 in 2010. And then in 1970, we had 9.8% of the population that were over 65. So by 2065, the 65 plus population is expected to be larger than the less than 18 population for the first time. So what does this mean for businesses? This means later retirement age, more costs related to fringe benefits and healthcare. For the government, it's a social security drain. For housing, it's less housing supply because elders hold on to homes for longer. And socially active elders rethinking elder and home care and family roles. Now, in Native communities, life expectancy is not quite as long as the national average. Life expectancy is lower for those with lower income, less access to quality health care. But life expectancy is still going up proportionally. Now, Native tribes and villages need to also deal with the altering infrastructure to adapt, but Native views toward elders may be the healing factor. Now that we have them, how do we care for them? Well, our two presenters today will tell you how their organizations have learned to calm the tides. So our grantees we're going to be spotlighting today is a South Central Foundation, which is located in the Alaska region, and Hope House, which is located in the Pacific region. We're going to be starting with South Central Foundation.
Hi, everybody. My name is Hi, everybody. My name is Donna Galbraith. I work at South Central Foundation. My title is the Senior Medical Director of Quality Assurance. I have been with the organization for about 13 years. I am a family practice doctor. I've practiced my entire career in the state of Alaska with Alaska Native American Indian people. Today, I'm going to give you an overview of South Central Foundation. We provide primary care for about 65,000 people. We have won the Malcolm Baldrige Award 2 times. We just won it in 2017. And that's a reflection of the quality of care that we give. And so with our NUCA system model of care, we have seen a decrease in ER use, a decrease in hospital rates. Our customers are really happy. Our employees are really happy. And we score quite high on most of the HEDIS measures in the 75th to 90th percentile. We're known throughout the world, and we have people who want to come and see our system of care, or they want us to come to their area. And you can see on a slide that it's throughout the world. So we travel quite a bit, and lots of people come here all the time to learn about our system of care. So this began in 1998 is when we chose to assume responsibility for the healthcare of Alaska Native people. The health system that we're taking care of is if you look at the slide here, the dark blue area with crosshatches on it, that's where we do primary care. We're located out of Anchorage, but we have clinics throughout these areas that are dark blue. The rest of the state has other regional areas that provide health care, but we provide pediatrics and OBGYN to the rest of the state. One other thing I wanted to say about that last slide is with the 229 federally recognized tribes, that's a lot of different cultures. So we have to be very careful with what we do and make certain that we're doing everything according to different groups, cultural values, and beliefs. And we actually have that built into our whole organization, which you will hear more about. So when we took over healthcare, we actually asked people what it was that they wanted us to focus on. And they shared with us top 5 needs. And based on everything they said, we changed everything. And so this slide shows that the healthcare system that we used to have on the top, that's the old hospital. It isn't around anymore. It got demolished. And down below is our new hospital and primary care. The primary care center is in the foreground. This picture isn't that old, and our campus has actually changed quite a bit because we have a lot more buildings on campus. We're growing at an astronomical rate. So we have customer owners, that's what we call patients. And the reason we call our patients customer owners is because words matter, and we know that words are really important. We feel that the word patient is a passive term, and that when somebody is a customer, there's certain expectations on the care that they're going to receive and also the care that you're going to provide that person. So we want everybody to be a customer. But we also know that American Indians and Alaska Native people own their own health care. They prepaid their health care through lands and through resources. So having that title customer ownership, it denotes a lot of things. It also creates a feeling in the person who is saying it because they want to be treated as a customer and they know they own their own healthcare system. If you think about it, anytime you own something, you take better care of it. I'm a customer owner. We want direct input from our customer owners, and we have done this since the beginning. So the first thing we did when we took over healthcare was to ask our customer owners what it is that they wanted. We came up with a vision and a mission based on Alaska Native cultures and values. So we want a Native community that enjoys physical, mental, emotional, and spiritual wellness, and we want to work together with the Native community to achieve wellness through health and related services. Our goals are shared responsibilities, and we mean with our providers and with our customer owners. We're committed to deliver quality service, and we recognize that family wellness is extremely important in our communities. We have leadership principles. We also like acronyms. If you look down the slide, this one says ownership. So our leadership principles are so that all of our leaders are aligned, and so that people who want to be leaders in the future understand what these principles are. as they're developing into that role. These leadership principles also intertwine with our operational principles. Our operational principles were created from everything that our customer owners told us they wanted. They want to be in a relationship. If you look, the acronym down the side is relationship. And as an aside, if I had to sum up South Central Foundation with one word, I would say relationship. We are relationship based. It's extremely important in everything we do. That's what our customer owners said they wanted. And they got tired. They said that they don't like telling their story over and over again. They don't like seeing different providers and different people all the time. They wanted to see the same people. They also wanted their whole family to be healthy, not just the individual. And that makes sense. I mean, an individual could be really healthy, but in our culture, they're not truly healthy if their whole family is not healthy. So the wellness of the whole person, the community, and the family is very important. We wanted locations that were convenient. We wanted access that was optimized. We have same-day access in our clinic. We want to partner with our customer owners. The design is a whole system design. Everything we do, we think about. We don't just willy-nilly do things, and we don't look at the latest and greatest. I mean, we look at the latest and greatest, but we don't just adopt it into our system. We may adopt aspects, but it has to be in alignment with what we're doing. We constantly measure. We have lots and lots of data because we want to make certain that what we're doing is effective. We also simplify all of our healthcare systems so that our customer owners aren't having to be sent all over the place. That's what people told us they wanted. They don't want to be sent to different places and have to make appointments all the time. So we tried to make it as simple and easy to use as we possibly can. The hub of the system is family, it's population-based, and everything is built on the strengths of Alaska Native cultures. These, as our operational principles, are things that we look at all the time. So anytime we're going to start a new service, we look at the operational principles, and it has to align. It doesn't have to align with every single one of those things, but it has to align with most of them. And if it doesn't, we don't do it. So based on all the changes that we wanted to do, we actually looked at the whole organization and figured out that we needed to change the organization to make it match the healthcare system that we were creating. We wanted our system to be sustainable. We also had to look at how we hire. You know, human resources is a big part of any organization, but we wanted to make certain that we were hiring people that would fit into our system. So we do behavioral-based interviewing so we can figure out whether somebody's a good fit or not. We also want as many Alaska Native people as possible hired in our organization. So we actually do a lot of development of our workforce. We put a ton of resources and money and effort into that. Finances being stable, that's really important. So we actually have replacement funds for all of our facilities and all of the care systems that we have. Our compliance and legal departments are partners with us. We have core concepts. This is actually a training program, and this is the underpinning of everything that we do. When we hire people, they're not necessarily trained in how we deliver healthcare, so we want people to be successful. So I've already mentioned we do a lot of education with our workforce, but one of the things that is done is the core concept, and every single employee has to go through this training. Our president and CEO, Catherine Gottlieb, thinks this training is so important that she personally gives this training. So you can say that she's trained every single one of our employees. It says wellness down the side. And basically what core concepts is it tells or teaches people how to be in relationship with other people, how to listen, how to tell your story, listen to other people's story. And you actually, you become more empathetic when you learn those stories. We want to honor others. We also want to honor ourselves. We want to have fun. We want to learn how to listen. We also want to learn about the differences in people, because everybody's different. We all have our strengths and our opportunities for growth. So we look at that because as a team, when you come together as a team, the differences actually make the team better, because people have different strengths, they have different ideas, they have different visions, and if everybody feels like they can speak up and say what they think, then whatever you're working on will be a better product. Because of how we operate, the providers and customer owners actually share responsibility in developing the plan for the customer owner, whatever the need is. It's not the provider walking into a room and telling a customer owner what they have to do. It's not giving them a prescription. It's not telling them they got to go exercise and diet and then walking out of the room. It's actually sitting down and having a conversation with the customer owner, listing out options for care, and the customer owner being engaged to ask questions and decide which of the options are best for them. So you come up with a plan together, and it's much more likely to be successful, and the customer owner is much more likely to be engaged if they have shared in developing a plan for their care and understand why. So I've mentioned some of these things. We have the same day access to primary care. So if I want to see my provider today, I can see my provider today. We monitor things all the time. And I mentioned our data. We are looking at things constantly. So we want to make certain that we're providing culturally appropriate care. We're looking at all sorts of operational measures. We actually measure our access to primary care providers, and we also look at waiting times. We have so many measures. I don't even know how many measures we have. I would bet there's 500 measures. I have no idea, but it's a lot. And some I don't look at. I'm looking more at the clinical, and I'm looking more at the operational, but somebody in finance is going to look at things a little differently, and they have all sorts of measures too. So our data is very robust, and we have a data team that just works on different parts of or different aspects of data that each of our departments want. So because our customer owners wanted to be in a relationship-based environment, what we came up with was integrated care teams. And so our customer owners are empaneled to a team. There are about 1,200 or less customer owners empaneled per team. And it changes a little bit because we also look at the people who are empaneled, and we risk-base them. So if somebody has a lot of people with complex medical issues, are going to have a smaller team than somebody who doesn't. So our integrated care team, the basic part is made up of the provider, the case manager support, and the certified medical assistant, and they all sit together. We're about relationship, and I mentioned that. So we want our teams to be in relationship too, because we want everybody to be working at the top of their license, and the only way you can do that as a team is to understand each other and to trust each other. And so you have to be in constant communication about the care plans that you're dealing with. We did away with offices. We don't have any doctor's offices. Everybody is located together. This is actually a view of one of our clinics, and there's 6 teams per clinic. We also recognize that behavioral health is extremely important. So we have behavioral health consultants, and we have them integrated into primary care. There's 1 to 2 behavioral health consultants per 6 teams, and it's always the same BHC. It's that relationship of peace again. The services that are co-located with our integrated care team, we try to have the same providers present so that the customer owners get to know the same people through time and build that relationship. So because we said, I mentioned that we wanted to make services really easy. So if I'm seeing a customer owner and there's something going on, maybe they're grieving, maybe something, someone died, and so they're going through a lot of grief, I'll have a conversation with them, and then I'll say, hey, Wendy's out here, why don't I bring her in, and you can, she can talk with you and offer you some different options to help you through this process. And Wendy would be a BHC. And then I would bring Wendy into the room and introduce the customer owner to Wendy if they haven't already met them, and then I would leave. They would stay in that same room, and then I'd go on to see other customer owners. We have an elder program. This is a very dynamic program that actually is growing by leaps and bounds, and there's lots of activities that elders can do right there in the center. We have lunches. We also have lots of activities. It could be shopping. It could be picking berries. It could be going for a drive. But just tons of activities for our elders program. There is also what we call the GWEP, the Geriatric Workforce Enhancement Program. This is a joint venture that we did with the University of Alaska, and it's to prepare the workforce for an aging population through education. So people sign up for this and they actually get credit at University of Alaska, and they go through this training, and the training is partially done on our campus, looking at using the NUCA system of care and how we support elders in our system. So we're training lots of people. We're training people within South Central Foundation. We're also training people throughout the state. There's even people at professors who are going through the training and get certification so that they can continue to expand their own knowledge and their own teaching around geriatrics. So one of the things we did is we looked at people who have the diagnosis of Alzheimer's disease and related dementia, and we looked to see what services they were utilizing within our system, because we actually had no idea. So we looked at it in 2016 to figure out where people were coming and how could we improve those services if need be, to meet the need and the demand in different ways. So this is some of the data we received. And one thing I'd say about the data is if you look at PCC, that's our primary care clinic. And so most of the people are being seen in our primary care. And that's a good thing. That's where we want people to be seen. The other places, we would want them seen less, because if we're delivering the care in the PCC, and they're getting their needs met there, then they're not going to go on to the other areas. But we all know they will, because sometimes people need to go to the emergency room and the inpatient. We don't discourage that, but we just want to make certain that we're meeting our customer owners' needs. So one of the things we also looked at was where were they getting their services before the diagnosis, and where did they get their services after the diagnosis. And so you can see, and again, this is just giving us information to figure out where we need to improve our services. We also are part of the Alaska Guild that is looking at the just geriatrics in the state. This program actually helps develop the curriculum for the GWEP program that I mentioned. It also does outreach and allows partnerships within the community around geriatrics. So some of the changes that we've done, well, first I should say, before I get into the changes, is a lot of the geriatric care, we expect most of it to be done within our integrated care team. So, we educate the providers where appropriate, but how we handle things that are sometimes specialized is then we have people who are experts, like in geriatrics, who can help our teams when they get stuck with a certain issue, or if there are needs that are not being met. So they can actually call this expert, or they can have a conversation, or they can meet with the customer owner and decide on the best treatment plan. But we still want the care within the integrated care team, because that's where the relationship is. That's where the customer owner is used to going, and those are the people they know and trust. So we just bring the services to the individual. One of the things we've done is we have a home visiting team. Back on the graphs, you can see that we had home-based services, but we no longer do home-based services because the regulations just became extremely onerous, and we were already operating the program in the red by millions of dollars. And we just decided we didn't want to do that, because we would have had to put a massive investment into the program. But we didn't want to get rid of home-based services completely. So what we did was we created home visiting teams and made them part of the integrated care team. So it's the providers who get to decide who needs a home visit. And that actually has expanded who are getting home visits, because it doesn't necessarily have to be an elder. It can be somebody who has needs and just can't get into the clinic. So our services overall have expanded because of that. We also, because of the home visiting team, it helps with transitions of care. So if somebody's hospitalized and they're coming back to primary care, a home visit can actually be set up also. And that's the end of my presentation. Thank you.
Next, we're going to be featuring Hope House. We'll actually be taking questions at the end of the webinar. So next up, we have Hope House in American Samoa.
So aloha from American Samoa. My name is Toitasi Fuetukenetanga, and I am the chairman of the board for the Pacific Youth and Community Development, the lead agency in Tausi Feanainga, or our Covenant Keeper project. Before we begin, I'd like to go ahead and start with a little bit of background on American Samoa. So in 1900, American Samoa was annexed to the United States of America, and it effectively split up the Samoan islands. You have American Samoa, which we're from, and you have Western Samoa, which became their own political entity. The two are not the same, and although we share culture, language, traditions, we are two different political systems. Now, the demographics of American Samoa are, according to the census of 2010, we have about 56,000 people, and 92% of those people are native Samoans. We have a per capita income of $6,300, and 61% of the people who live here in American Samoa live below the federal poverty level. 63% of the total labor force is either employed by the government or by the tuna cannery, and the rest of the labor force is employed by tuna cannery related businesses and the private sector. American Samoa has a depressed economy that's heavily impacted by the fishing industry. We have no tourism to speak of, very little. We get the odd cruise line that comes in maybe about 12 times a year. So that's about once a month. It's considered a day trip, so they come in the morning and they leave it in the evening. And there is very little opportunity in the private sector here in American Samoa. In talking about the cultural backdrop of our program, American Samoa is arguably the oldest surviving Polynesian culture. We have what's called our Matai system. And in our Matai system, we have titles, and it's based on tradition. Everybody is a part of a nuclear family, which is in turn a part of a more extended family. And each of these families have titles. We have a hierarchy of chiefs, and the building blocks of that unit are the villages, the counties, and the district. And things are ruled over by all the activities, cultural activities are ruled over by a council of chiefs, both at the village level and at the county level and the district level. Our lands and titles system, the Matai system, as well as all communal land, which we have 97% of land here is communal, are still controlled according to our native customs. We have 86% of households that still speak the native Samoan language, and 98% of American Samoans are Christian. Also, as part of the backdrop is American Samoa's commitment and dedication to culture. American Samoans believe steadfastly in, we care for our own. Caring for our elderly is considered a show of respect and compassion. And it's if I could put it in my own words, it would be, thank you, Mom and Dad, you cared for me when I was young. Now it's my obligation to care for you. It's considered a reciprocity of love, care, and respect between parents and their children. And so we named this project the Covenant Keeper. We toiled around with the name Promise, but this sacred obligation that Samoans view between a child and their parent is more than just a promise. And so we termed it covenant, that we, through this program, we seek to keep that covenant between children and their parents. The expectation here in American Samoa is that when you get older, you're going to care for your parents. As they become infirm, as they become elderly, that is your sacred obligation, not only to your parents, but it's also part of your obligation to your culture. And, you know, I can tell you when I was growing up, and as a lot of people believe now, it's an unspeakable shame if you do not care for your elderly, if you do not, you know, if you abandon them, if you leave nobody behind to care for your parents. And so that brings us to today. And there's a lot of changes in today that have affected this covenant between children and their parents. The most, or at least the biggest change is your reliance on, you know, the economics, having to make money in order to provide full-time care for your parents. Today, as in the past, you could farm, you could fish, and whatever you were able to get as part of your fishing, or whatever you were able to raise as part of your crops, that went to caring for your family. In today's world, though, there's less and less farming and fishing for subsistence, and a lot more on getting the office job, making money, and then using that money to pay for services such as caring for your elders. The increased cost of living, nobody needs to be you know, told about this. Cost of living you know, continues to increase from year to year to year. And this results in a situation where every able-bodied person who is not at school, who is in the household, has to get out there and get a job and make money. This results in, you know, an elderly parent who's at home and who needs to be cared for is either cared for by somebody you know, who is not a family member. Sometimes American Samoans will bring in relatives from Western Samoa to care for their elderly. Families having to make a desperate decision of, do I work or do I stay home with my elderly parents, are choosing to leave the elderly parent at home by themselves and going out to make money in order to provide for the family. The elderly and severely disabled population here in American Samoa, they require care that's below what our hospital can provide, which is acute care, but above what our health centers can provide, which is basically outreach and appointments by, you know, that you have to physically show up to their facilities in order to do. And so this was the impetus, you know, for this project, upskilling community caregivers and institutionalized caregivers in order to care for those elderly folks in their home. So among those conditions, in addition, poor people plus non-subsistence farming and fishing equals poor nutrition and poor health. This is part of American Samoans going away from traditional subsistence farming and agriculture. That physical activity that they got out of agriculture and fishing is gone now. It's replaced by, you know, basically working a desk job and earning money, using that money to provide for the family. There's a prevalence of obesity and being overweight. And American Samoa has one of the highest rates of diabetes in the world. And besides diabetes, we have those other NCDs that accompany obesity. We have hypertension, high rates of heart disease, high rates of stroke, as well as other dietary maladies such as gout. Here in American Samoa, there is a very alarming increasing trend in dialysis. The number of patients over the past 5 years has tripled for dialysis patients. These are people who are facing end-stage renal disease, renal failure. There's an increasing number of disabled patients due to amputations, and these are mainly caused by diabetes, one of the symptoms of which is poor circulation. People who are disabled because of stroke, and the high aging population that we have here in American Samoa increasingly are, besides the care that's provided for them by their family, are also on food stamps. They access services for senior citizens and elderly through our territorial administration on aging. And so with all that in mind, your families just can't afford these days to have anybody stay at home and not go out there and work in order to earn money. And so, this home care is just something that is just out of their reach. It's unaffordable. Sorry. So we have, in this project, we began with our problem statement. And that's that over 65% of American Samoa's elderly and disabled populations live in isolation with limited access to proper health care, and that results in premature death. Part of that isolation is a lack of resources to get these people out and back into the community. We've had some very promising things that have happened within the past year and a half. We've gotten a program that provides 100% subsidized transportation for the elderly and for the disabled. But still, by and large, the elderly and the disabled populations are still isolated in our communities. Now, the goal, of course, with this problem that we have is to increase the number of people who have the requisite skill level, the requisite attitude to go out and into the community and provide home care to these people, to these elderly patients, to these disabled patients, which are referred to in the Silver Tsunami.
Aloha, I'm Beatrice Block, Project Manager for Project Tsunami, translated as Covenant Keeper in the Samoan language. Project Tsunami is funded by the Administration for Native Americans through a partnership with the Pacific Youth and Community Development and the University of Hawaii's John A. Burns School of Medicine to allow caregivers here at Hope House to receive medical training. The official launch for Project Tsunami was on May 14th with an opening ceremony attended by board members of the Pacific Youth and Community Development, board members of the Catholic Diocese, Samuel Kongpang, First Lady Cynthia Molinga, the team from Hawaii, as well as project participants. Training and instruction commenced on May 20th with the lead trainer from Hawaii, Dr. Ridobel Fernandez, giving a lecture on normal aging and the principles of general care for the elderly.
Because what tends to happen in elderly, a lot of people aspirate and they go to hospital with aspiration pneumonia.
Following thereafter, we have Dr. Shelley Williams, who gave of her expertise instructing in the areas of principles of adult teaching, as well as learning role play, which is vital for the next step of Project Tsunami's second phase, which allows the students to become teachers. Day 2, Sandra Scanlon, the physical therapist from our local hospital, the LBJ Tropical Medical Center, taught on gait and transfer methods, giving an opportunity for the participants to perform exercises utilizing assisted mobile devices. Dr. Nafanua Berginski taught her portion of the training in Samoan, teaching the students a module on activities of daily living, allowing the students to provide a return demonstration on their skills to showcase competency. Dr. Lan Wen shared his knowledge in the classroom, lecturing on arthritis and fall prevention, in addition to the management of difficult behaviors. Dr. Wen specializes in pain management for the end-of-life support. Dr. Brett Flynn was able to cover the area that many residents experience is bed sore and bed sore prevention.
Now it's going to be the hip, the shoulder, his ear.
Dr. Fernandez wrapped up the training on Friday, May 20th, with a lecture focusing on caregivers, where she taught on relieving caregiver and family stress, along with resources for the elderly. To officially close our training event, Pacific Youth and Community Development hosted an appreciation ceremony on the evening of May 20th to recognize the experts and caregivers from Hope House. The program participants received certificates of appreciation, while the instructors from Hawaii were treated to a traditional Samoan farewell ceremony. This hands-on training is a portion of Phase 1 for Project Tsunami in 2017. For our next portion, we will welcome again the team from Hawaii for Phase 2. Project Tsunami is proud to be part of a great partnership between the Pacific Youth and Community Development, University of Hawaii's John A. Burns School of Medicine, the Diocese Samoa Pongpang, funded by the Administration for Native Americans. Patsai.
So for this project, our primary partners were the Catholic Diocese, which operates the Hope House home for the elderly and severely disabled or severely disabled individuals, including children and adults. The University of Hawaii, John A. Burns School of Medicine, as well as the various public service agencies that serve as referral access points for the project. These include the Territorial Agency on Aging, Human and Social Services, Department of Health, etc. So one of the key elements of our training program is the fact that we were able to really tailor and customize the training to address the issues of our population. And these were the first line beneficiaries of the project, the caregivers that work at Hope House. And when we developed the program, we had to take into account that a lot of the ladies and the men that work there basically learned their skills on the job. Some of them had worked there for about 10, 15 years, even further than that, under the supervision of the nurses, the nuns who had established and provided care through Hope House. None of them had had any formal training. For many of them, they speak English as a second language, so English was a barrier. So we had to take all of these into account as we developed the training program. So we wanted to make sure that we designed it around adult learning styles, that we built in a lot of hands-on experiential learning time and activities. We wanted to make sure we built in a lot of live translation and supplemental materials. So one of the neat things about this project is that we partnered up with Dr. Redabel Fernandez out of the University of Hawaii, and she and a team of her professional colleagues who specialize in geriatrics had actually developed a certificate and ran it through Palau. And they ran it once and intended for it to run throughout the Pacific jurisdictions through the AHEC program. However, it didn't take hold in some of the other islands. So we were able to build on that work and have them come here to American Samoa, adapt the certification to meet our training needs, and be able to bring in a team of specialists that specialize in different areas such as end-of-life care, pain management, bed sore prevention. These are people who bring in just a wonderful, rich world of experience that our caregivers are able to learn from. So we were able to have a on-site, accelerated, very intensive face-to-face training that runs once a year for about 2 weeks. And then we follow that up with monthly webinars. Now, knowing that your frontline caregivers who are training participants and are interns in the program, and their English language comprehension skills are sometimes on the literacy side. So that makes it even more important that we have translation, that we also take the curriculum materials from the certification program and we supplement that, and we translate the handouts, we translate the evaluations, we translate everything to make sure that they walk away from this training program with a full understanding and comprehension of the skills that are being learned, why they're important to know, and how they would apply it on a daily basis. The other element that we added in there was building capacity of peer mentors. So we've got this core team that works out of Hope House as full-time interns, but we wanted them to be able to then serve as peer mentors and trainers for community participants that were coming in from the community. They've by far and large got the most experience as far as taking care of the elderly folks, and we wanted them to be able to serve as role models for the others that are coming in. So what we're presenting as an effective learning model that's worked for us in this project takes people through this cycle of skills development, and then they go into practice and application. We emphasize this practice and application time to run from about 6 months to 8 months, and that's the best way that people can learn. And through that application, they're also getting a lot of monitoring and observation, a lot of supervision that are provided by shift supervisors, clinical nurses, evaluation that happens on an ongoing and routine basis to make sure that at every level of development, our trainees are demonstrating that they have mastered the various skills that are included in the certification. So we're going to close this out. The impact on our target population is we've been able to afford them more access to primary care. We've been able to help them live more independently with some state of normalcy. We've been able to provide immediate services for those that are higher risk. There's better medication management. There's a closer working relationship with the doctors from Department of Health and the hospital. We focus more on preventative care. There is a lot less incidences of bed sores, and because they've been working more on bed sore prevention and wound care and making sure that they prevent it in the first place rather than dealing with infection and everything else that comes along with that. And they've also been working a lot on fall prevention strategies. Our impact on the community, we've been able to improve the quality of care for the elderly and disabled folks that we serve. There's clearly an increase of skills and knowledge of caregivers, and we're happy that we've been able to create a new pool of health paraprofessionals that can join the workforce and hopefully become paid or reimbursed through Medicare and Medicaid funding that's available for community-based caregiving. And naturally, with increased rates of employment for those who've been able to get trained and then become hired as full-time caregivers, or we've definitely been able to impact people having more marketable skills. And this is our last slide where we talk a little bit about long-term sustainability. So one of the things that we're very proud of with this project is we've been able to create that infrastructure for training the people who are interested in community and home-based caregiving. We've got the curriculum, we've had the training provided by the experts in geriatrics and the medical field from off island, and they've been able to build up this training network that's available now through Hope House and this project. And we see it as a building block for training CNAs and other nursing professionals, which is the next step in our project. Hope House will now be able to serve as a hub for comprehensive services for this particular population. And we will continue to look at accessing funding through partnership agreements with the hospital, public health, and the Medicaid office. And I think we have reached the end of our time. So we will close out our presentation, and thank you very much for your time and attention and your participation in this webinar.
So we just wanted to thank our two grantees for their presentations today. And if you guys have any questions, there will be two emails that'll be sent out after this webinar. You can just reply to either of those, and we can send it directly to the organization that you are wanting to speak to. Other than that, you can find this webinar on our ANA Pacific Basin page. We're going to try and get it up as soon as possible. And as always, if you have any questions, feel free to contact your regional office.
All right, thanks everyone for attending, and thank you, Shisa, for hosting today's session. We also have, came to our attention that a few attendees had some difficulty seeing the PowerPoints that were on screen. So if you had any difficulty with that, we'll be sending out, like Shisa said, a video recording of this session by email early next week. And you'll be able to see the visuals there, and then of course reply to that email with any questions you have for the presenters. So thanks again, and have a good week. Aloha.